In today's episode, we're going to talk to Dr. Morten Høeg from Denmark, which is pretty close to where I am. It's only like 120 km further south. And we're also going to talk to Associate Professor Tasha Stanton, who's a bit further away. She's probably more like 25 hours in a plane. Both of you, welcome, and thanks for taking your time to participate in this podcast. We're going to talk about your latest editorial in BJSM, which I found very interesting. But before we dig into that in more detail, could you please present yourself for the listeners?
Sure. I'll start us off. Thanks for having us. First of all, I'm very excited to join. As you mentioned, I'm an associate professor and I work at the University of South Australia in Adelaide. And I have been, interested and intrigued by pain for probably about 15 years now. I did my original training as a physiotherapist and then got my head stuck into some clinical pain neuroscience. And so I really, I guess, am motivated by trying to understand a bit better why we have pain and why sometimes it becomes persisting or chronic. And I guess as part of that, I'm also quite interested in understanding how pain works in various different populations. So people with osteoarthritis, back pain, complex regional pain syndrome, and then most recently with some of the collaborative work with Morten, looking at athletes. So I am a little bit all over the place in my research interests. I do things from virtual and mediated reality to, systematic reviews to looking at clinical trials. But ultimately, most of my research is really targeted at trying to, create better new treatments for pain.
Excellent. And I can cope with that. I'm first of all very happy to be here. It's a pleasure to be with both of you. It's good to see you both. And now we have video on, obviously you only have the audio, so it comes as no surprise that I'm slightly older than Tash. So I've been in the work of sort of pain related things for approximately the same time, maybe a bit longer. But I started out as a physio, working in the clinic and managing all these pain conditions. So I feel like I've been through what has been addressed by David Butler as the roller coaster of the professional life, having gone with all these theories and ideas of why we hurt, and then looking for the why and treating the why, and then in some cases having the success of seeing the pain disappear, and in many cases maybe not so much. And that was quite engaging, and that really helped me try to learn more techniques and understand more theory. And it wasn't really until I stumbled upon this idea of pain as a science in itself, first brought to me in the sort of context of Explain Pain, the book, and then it sort of accelerated from there. I started to do a lot of digging in and trying to understand the world of neuroscience through weekend courses and stuff, and I couldn't quite feel my desire to know enough, so I ended up doing an MSc program at King's College in London, a 2-year program with Professor Mick Thacker, and then came home and still had this flame of wanted to know more, so I engaged myself in a PhD, and slowly I've retracted myself from having an everyday work in a clinic to having more of an academic life with a foot in the clinic still. So I do see patients, and I do manage patients and work as a clinician and all of that, but to a much lesser degree than I did in the first 15 years of my practice. So that's where I am now, and I was going to say just like Tash, but I won't compare myself to Tash. So I haven't by any means done as much research and been in the clinical world for as long as she has, but I am a bit all over the place. My PhD was in basic science, trying to study healthy humans and how they respond to pain, to see if we could tease out some sort of mechanistic approach to understanding why some people get better and some don't. And now I'm more in the sort of clinical end of it, trying to implement what we already know and see if we can improve care and implementation of the knowledge we already have. So for me, I think that's a nice stretch. I'm lucky to do a lot of work with a lot of people that I admire and feel comfortable being around as persons as well, Tash being, of course, one of them. So I just feel very, very honored to be in the position I am. And again, thank you for having us today and discussing some of the work that we've just recently got published.
So I think I'm the one that's happy to have you both, as I said. So let's dig into it. You've made this editorial in BJSM, Pain or Injury, Why Differentiation Matters. Could you kind of highlight why it's important with the differentiation and this subject? Why do we need to take that up? Isn't it obvious? Or
well, I can kick it off, and then Tash can follow, because it started when we were discussing at the university. We were discussing this frustration that whenever there was an article on anything sports related coming out, it was, there was a sort of synonymous idea of being in pain and being injured that was similar. And then we had a look at just a quick dive into the literature, and we could see that the majority of research would, even within the same article, they would switch between pain and injury as completely synonymous, and in others they would stick to one or the other, but there weren't really any definitions. And then this sort of hybrid term of an overuse injury, what is that really? And the frustration then sort of grew, and we had a talk to Tash and Steve and a few others about it. Stephen George, who's also an author on the infographic. And we agreed that it seems like we are not the only ones who have an understanding that we can be much more precise, but also that precision in our wording and semantics could actually have true clinical impact.
Yeah, and I think what I loved about those early talks so much was really that how much we were, I think, on the same page, despite sort of coming at it from different angles. And I guess for me, one of the challenges that I see with, as Morten used the term imprecision, but imprecision with terminology, is that certain words give cause and give meaning to different people. So sometimes maybe if us as clinicians, we might be saying injury, but we might not necessarily mean still actual tissue injury. Although in some cases, I think actually there is confusion between the two in clinicians. But I think the challenge you have there is that when you use terms like injury, it provides a visual image, it provides a mental image to that athlete, in this case, of something that actually is not up to standard, something that is still broken, something that still needs to be fixed. And I think the challenge you have with that terminology and narrative of needing to be fixed is, again, you're stuck down this route of looking for a cause. And as we, I think, are very well aware, and the scientific evidence is beginning to build up within this, is that particularly when we have pain that is persisting or sticks around, we don't often see that there is one cause or one thing driving it. Often it is a multitude of factors that are contributing to anyone's experience. And so unfortunately, creating a narrative that it solely focuses around injury also completely then reduces any need or why on earth we would ever think about looking at psychological or social factors, because why would that matter to an injury? And I think that's an absolutely fair thing to ask, because it doesn't make intuitive sense. So I think with the use of the term injury, we imply a lot of things to the athlete, but we also then limit our scope of available treatment, because I think you've already lost buy-in by framing the situation in a certain manner. So I think that there's a lot of different courses and sequelae of the use of these terms. And I think that's what I was really most interested in discussing and trying to get on paper.
So do you think that,
and I guess,
you just go ahead, Morten, you and Tasha.
I was just reflecting on what Tash said, and one of the things that was frustrating, and I assume would be frustrating to many people in the pain-ish related world, is that we now have a complete and profound understanding of low back pain as being a non-nociceptive disorder. So you're not having a single thing in your back that causes the pain, which is completely different from how, you know, I was brought up and learned, you know, on the courses I attended. So you would always look for the thing, whether you're doing one guru-based treatment or another, and then you would treat the thing. But in low back pain, that is, you know, I would say probably the seminal papers would have been the Lancet Low Back Pain series in 2018. That was sort of a turning point where now you can publicly say that we don't know why you have low back pain. It's, you know, the best way to perhaps say this is multifactorial, so you cannot remove one single factor and, you know, believe that pain will go away forever. So this is what we are talking about on a normal basis, a daily basis, on musculoskeletal pain as general. But then you have this field of sports medicine, which has been sort of, you know, coated with Teflon in the sense that it's strongly biased towards an understanding of treatment is to some extent equal to a bit of education, but then most of all, it's loading or unloading. And I think that's why we would all agree that this is, you know, such an obvious thing to state, but if we don't know, because that is consequently that the issue here is that when people are not specific in what they mean, we don't know how many are actually injured and how many are not. So we're looking into a cohort of young athletes with shoulder pain currently, and trying to sort of reverse engineer what are the most likely terminology to use when someone comes in with shoulder pain during handball practice. And it's really difficult to see that we have any specific tests or anything unless you have this very acute condition where you are not in doubt, and you probably have sent people off to an emergency room anyways. So they're really rare, these acute arising tissue injuries. And that, of course, spans over the spectrum to a completely multidimensional chronic pain condition. But the interesting bit is, of course, where does one stop and where does the other one start? And how does that sort of slide into each other, which is, I think, where the whole idea of overuse problematics come in. So you would say, if you don't understand it, you say, well, it came over time and it's probably because you used it too much. Now, using those words, coming back to what Tass was saying before, does that also mean that by using it less, you'll be better? Or is, I mean, that would be the logic of saying overuse. Is so if I underuse it for a while, it should be better, shouldn't it? If you are in a healthy body. But we all know that that isn't the case for many, you know, Achilles tendinopathies and you know, patellofemoral pain and whatever you call it. So we try to put some words into that spectrum.
So what you're saying, both of you, is that the wording dictates the narrative, and the narrative somehow dictates how we're looking at it, how we're treating it. And you want to highlight the difficulty in that, right?
Yeah, because I do think that sometimes I think we presume, for example, that athletes, you know, they have such a good sense of their own body. And in many ways they do. But for many of them, they won't have received a very in-depth instruction of, you know, the anatomy, how the different parts of their body work in terms of your nervous system, all these other systems that are involved. And to presume that then they have an accurate, even expectation around that injury becomes very difficult, because we're also not providing some of that base education that people have. So I think in some ways, we don't even know what athletes think when they hear that term injury. And I think it matters. It will be different for different athletes. So, I mean, I certainly see from the literature in back pain, when you have people that often get quite anxious and quite fearful in terms of certain types of pain that they experience or certain conditions that they're in, that can really go down a poor slippery slope quite quickly, where suddenly that is it's fear and it's anxiety that are actually the things that you're fighting against to try to get people back to sport, rather than possibly the pain that they're feeling. Although oftentimes we do see that those high levels of anxiety and fear and pain high levels of pain go hand in hand. But I think that to me is a really important consideration, that we, I think, have a role in ensuring that an athlete does have an understanding of what's going on, so that not only we can ensure that that is accurate, or as accurate as we're able to make it, but that so we can also promote some of the, I think, positive possibilities rather than all the negative possibilities. So even with, for example, an acute injury, the fact that if you have swelling or, you know, inflammation right away, gosh, that's your body doing exactly what it should. Like all of those processes, that's exactly what they're there for. You're already starting to heal. And I think that sometimes helping to frame some of those things in a certain manner that is potentially aiming to reduce that potential fear and anxiety is quite important. And I include within that the way that we use and talk about injury terminology.
Yeah. Yeah, I think it's very important that we touch upon that we frame it in a different way. And I don't think the athletic population might be that different from the ordinary person walking in. But I think they might have a shorter period of time where they have that identity, and that somehow makes them more vulnerable compared to how they're looked at from a public point of view. And I think that becomes an issue, because we've seen also in the paper by Evans from 2012 that when they're injured, they're going through different stresses. So there's definitely something going on that we need to attend more than just the injury. So I'm totally agree on what you're saying there, Tasha.
And I think there's it's something we talk about in the infographic as well, is that if we then again have this spectrum of someone having pain as the cause of what they have for whatever reason, so you call it a type of chronic pain, and you could have this very acute injury, which is going to be, in most instances, people will have pain at the same time. So we need to remember that the pain people feel will be the same across the spectrum. So it's not as if pain in one end is different from pain in the other end. So it's not like, the one pain feels like a tense muscle and the other one feels like a cramp. It's just the same pain. So how we feel and how we perceive the pain is completely individual. And we can't say that whenever you use these words, you are in one end and these words are in the other end, sort of idea. So we need to understand that if treatment doesn't change, maybe the pain is the thing that we want to go for. So just trying to cut it down and keep it simple. If there's a tissue injury, let's say there's a broken bone or even an infection or serious pathology of some sort, then of course you need to attend to that infection as well as the pain. So we are not saying that it's either pain or injury, we're saying it's both. But that's in one end of a spectrum. In the other end of a spectrum, what might happen is if you cannot find the thing that you think is hurting, you keep sending people off to different assessments and x-rays and MRIs and stuff. And we know again from back pain that there's a strong association between having early MRI scans of your low back for low back pain and the prolonged time it takes you to get back to work and get rid of your disabilities. So why are we exposing athletes to that when we have the knowledge? I mean, one argument could be that athletes are different from low back pain populations, or that limb pain is different from low back pain. We just don't know. So we're trying to take the first step into pointing in a direction and say, if that is the case, maybe first of all, something we should look into. And second of all, maybe we can use some of the knowledge from specifically low back pain, but I would say generally on musculoskeletal pain from non-athletes, and use it into looking at the athletic population as well.
Yeah, and I think that's really quite relevant, Morten, because I think the opportunity for iatrogenic harm from imaging, it's not unique. So like, it's not unique to a non-athletic population, because as you mentioned, having, always searching for this cause, particularly when pain is persisting and possibly sending people down larger surgical routes or various different things, that clearly occurs, and that can really be problematic. But I think it also can be, if you're getting some of those scan findings, how much is that actually changing the way that your system is protecting your body? Because now you potentially have this credible, believable evidence that there's actually appears to be something wrong here. And yet, of course, we know that actually many of the findings, particularly for lumbar scans that we see, are very common in people who are asymptomatic. So they tend to be more age-related findings rather than specific features or pathological changes. But I think that aspect of knowing when to image and when not to, it is a hard one. Because I mean, there are clear situations where imaging is relevant and important in sport. We think of, ruptured ACLs and various things like that. But I do think that there needs to be a greater conversation about when to use imaging and for what sort of cases, because, and this is absolutely anecdotal level evidence. So everyone listening, low level evidence that I'm talking about here, but the number of, sports teams that I've consulted with. So a little bit of work with the Irish rugby team and Tennis Australia, and numerous of those clinicians have stories where their athletes have happened to be involved in perhaps a research study or some sort of investigation where they've just had a scan for some reason, and they've seen something on that scan and they subsequently develop pain. And this is not something that you would expect, okay, this scan is picking up something early. This is an athlete that has had no problems, that has really been, functioning very well. And for some of them, that derails them. So I think that, I guess, the idea of the infographic is to really foster conversation about some of those things and get a sense of what can we do to optimize the technology that we have to be using it in the situations where it is most meaningful and it will most influence clinical course and management in a positive manner, and do our very best to identify and avoid those situations where potentially what we're doing is taking it down a less than optimal trajectory.
Yeah, and just on that, oh, sorry, Brian, you go ahead.
No, go ahead, Morten. You're probably wiser than I am, and we're at the same age, so wiseness makes it this time.
Okay, I'll kick in then. Again, I would say the sort of simple question here is whether or not using excessive or extra assessments is really gonna do a difference for the therapy. And then of course we have on a spectrum. Again, if you have the ACL and it would be beneficial to know, is there any subchondral changes or damages or whatever. So these are things that are really important for rehab as well. So you need them in order to design your rehab. You can also have conditions where, so again, amongst the athletes I see, there are some who are extremely fearful about their bodies. And they have this idea of the MRI scan being the sort of golden thing that can really help them. And I've come to understand that it can be used in a therapeutic way. It's not something I would recommend, but I mean, in the case where someone is deciding that they want the scan anyways, then at least having the chat that we will see things on scanners and what are the things that are relevant to manage. So these are your symptoms. What are the common findings in a person? So I see a lot of athletes doing gymnastics and so extension rotation sports. So majority of them will be exposed to the conditions that might correlate very well with spondylolisthesis. So unless the symptoms are completely identical with the ones you would see and they are disabling, even having a spondylolisthesis is not gonna have any influence. But having that conversations before the scan is really important. So I of course don't have the need to send people for a scan, but I acknowledge that in the pain world as well, that when the pain is the problem itself, there can be things that are relevant to either know that it's there or to have visual identification that isn't there. So it can be used, but just using scanners because you don't know what is wrong, I think that's the thing that we would generally, not just those of us here, but generally that's what we are trying to avoid, is that we just send people off because this misinterpretation that if you cannot do your sport, you are injured, but we cannot treat you until we know where the injury is. that's a sort of trajectory that we really want to change and create a new narrative. Say you don't have an injury, but you have what we call sports-related pain. Pain can be managed in so many ways. So we are not only looking at loading and unloading. We have so many tools here that we can actually apply you with or support you with.
Yeah. Don't you think it's because within the athletic population, there's a very strong culture of using high-tech technology? And I think that culture kind of dictates what you and I are looking at and need to be done. So it's maybe we're doing this a bit in reverse now, but I think that culture kind of dictates the rest of the society, and a lot of the expectations the normal human being, like the industrial athlete, comes in with. So I think that's a lot of education, Morten, not just in the talk, but in the talk with the peers, the strength and conditioning coaches, their coaches, to give it a better understanding that way. Tasha, you mentioned like education. I just, based on my own experience 20 years ago and what I've seen as a clinician now working with this population, the culture is so strong. And if we as clinicians doesn't help, then we just bring in the MRI, and if that doesn't help, we bring in the injection and the ultrasound. If that doesn't help, we bring in the surgery. Now we're bringing in larger and larger cannons, and we're doing it very rapidly compared to what we know would make sense. So there's a culture that kind of dictates, and that's why I think your editorial becomes interesting, because that culture, in my way, will need to change, or at least be flipped just a few degrees.
But
yeah, that's a really... Sorry,
yeah,
go ahead, Martin.
No, you go ahead. This time, age doesn't have privileges.
I was just going to say that this is it. I think that's a very important point that you bring up, and that is the cultural milieu that exists within a certain area. And I guess one of the things that I think is a relevant thing is even if it can start conversations, in the sense that not everyone is going to feel comfortable to delve into, for example, psychological or social factors that can be influencing pain. And so I think it's identifying within the team who feels comfortable with what, where is everyone's strengths. And if people don't feel comfortable with it, that's okay, but it's at least then probably getting everyone's terminology up to a specific level so that there's consistency of message. So there's a standardization, because truthfully, there's probably nothing worse than hearing one story from one person on the team and then not hearing the same thing from someone else. And I mean, obviously, there's a lot of team meetings to try to avoid that from occurring. But I think if you are talking about a cultural shift, it inevitably will happen, because people will still use old terminology that they're comfortable with, that they're used to, that actually, if you think deeply about it, will actively contradict possibly some of the other messages that are given. So I think in some ways it almost merits a field rethink of how we might talk about injury and pain and how different professions might do that.
And and talking about the whole team, and I think one of the things that people may struggle with is this idea that if there's no injury, then it's psychosocial. So this misguided understanding of what George Engel and the psychosocial model, the biopsychosocial model, was really meant to be. So when he meant it was a systems model, so you were looking at molecules or persons or societies, and you would see different aspects of the same problem, rather than what people have thought it is, namely that you have a biological problem, i.e. an injury. If you don't, then it's a psycho or social problem. So the worst sort of trajectory here would be that you have a person and they have no injury, we all agree, so now they go to a shrink or to a social worker in order to rehabilitate their pain, which is completely and utter nonsense. But I think that's also what happens when people don't understand the construct of what pain is and how pain works, is that they think when they can't see an injury, well, the pain has to be caused by this linear approach to understanding pain, caused by thoughts or beliefs, when in fact what we see, and that is, I believe, quite well documented, that, for instance, people who are returning to sport after injuries, let's say an ACL injury, some do and some don't, and it takes time and it takes effort and they need to strengthen their tissues and all of that. but what it also takes is you know, they need to either dare it or believe in it or have the faith that they can actually do it. And some of that might relate to, is my knee safe enough to do it? Or it could even be, do I really want to go back to it? But there's so many personal thinking and thoughts and, you know, aspects of going back to sports, that these are things that we now have a good understanding of can also contribute to the intensity and maybe even the location of the pain you feel. So rather than thinking that pain is either biological or psychosocial, it would be beneficial if we just acknowledge that pain is pain, and you will have pain for some reason or another. But in the majority of cases in musculoskeletal pain, we simply don't know why. And what we think is that it's multifactorial. So there are so many factors that even if you change one or two of them, let's say you change the tissue loading and you're thinking about it, maybe that's sufficient, maybe it isn't. But again, if we are on that spectrum of dealing with chronic or long-lasting non-specific musculoskeletal pain, which we now see in, you know, many aspects of the limbs, not only the spinal pain, we can do so many things. And first of all, and I think this is one of the things where I have surprised and helped many athletes, is when they are not injured, but they are, I was going to say only, but I don't mean it, solely paining, so they have pain, but they're not injured, then allowing them to go back to sports with their pain sometimes is the way through. And I you know, I saw this plenty of times when I was younger and working in a clinic, and you would have this resistant, let's say, Achilles tendinopathy, and you would do all sorts of things, and then the patient stops and they go about their things and they go back to sports, and then you meet them a year or two later down in the supermarket, and you, how's your Achilles, you ask, and they say, well, it's all fine. It really helped when I started playing sports again. And, you know, I couldn't understand it, and I felt like a bad therapist, when in fact I was just not aware that there was a spectrum here. I thought that all pain equaled injury. So every time you were hurting, you were injured, and I would look for the injury. And we now know that isn't the case.
So it definitely comes back to knowledge and awareness and clinical reasoning, Morten.
Yeah, professional development. I mean,
yeah.
Basically embracing the fact that we now know more than we did before, and all of the theories we have and have used for so many decades, they're all beneficial, and we are standing on the shoulder of giants. I'm not in any way saying that there's no relevance in tissue changes or anything. I'm just saying, let's have a look at the evidence and try to see, would it really matter? Let's say you, again, looking at a tendon somewhere in the body, let's say you find a different looking or pathology looking tendon on an ultrasound scanner. Does that mean that you have to change the tendon for that person to return to sport? I would argue that it probably doesn't. So even having that scan is not going to change the therapy. And I think that's the discussion we need to have. In fact, that's the discussion I hope to be having in Monaco in 2 weeks' time at the IOC Prevention Congress.
I think what you just said, we need to have this discussion, which has been said before today in different ways. I think that could take us very far away right now. We could spend several hours on that, because I think you're right, Morten. We tend to be like, this is my camp and this is your camp. And we're really not that good at listening. I mean, you can walk into any clinic and people would say like 90% of my patients are giving shockwave, and the other ones would say, why on earth are you doing that? You're such a jerk. You're not listening to your patient. I mean, that's where we are most of the times, instead of listening and providing each other with how the development has been within the profession. But that's a totally different talk, though it's very relevant to making the editorial. I get that. Now we got a fourth member on board. We got a kitten that's not sleeping anymore. This is massive. You've got some statements in the editorial which I would like to dive into. We've already covered some of them. Would you be okay with diving into those? And that's just yeah, that's nice of you. Okay, let me do the first one. The first statement is, first, benign and normal fluctuations in pain may be seen as a sign of sports-related injury, which could impact performance negatively. Morten, I think you covered that somehow by saying that what we see things on X-rays and we think we're too injured that where we can't go out and do our job as an athlete. Could you expand a bit more of that, what you mean by negatively?
Yeah, I mean, again, coming back to the literature on low back pain, which is where we have the most solid evidence. We have very good evidence from Denmark, Lena Hesbæk and Jan Hartvigsen, of course, and Alice Kongsted, who've done a massive amount of epidemiological work on looking at the trajectories of low back pain. And what they find is that if you follow, people with low back pain over a period of time, you would see normal fluctuations. So in order to understand how is pain normally for a person, if you wanted to sort of conceptualize that and bring it into a clinic, I mean, the best learning you could do is listen to the patient's story. How has it been before? And if you have an athlete and they have had, ongoing knee pain for maybe 2 or 3 years, well, what are the chances that you can do an exercise and make that pain go away unless there is an identifiable single cause leading to nociception, which we understand can be a driver of pain? So if you cannot find that, how relevant is it really that we go on and treat the knee as a single problem, when in fact we have a history of continuous knee back pain, I was going to say knee pain, and the other approach would be to simply say, well, it seems like you've had this pain and you seem to be an expert. You've had it for maybe 3 or 4 years. You've managed for 3 or 4 years. How are you doing that? Learning from the patient, I think, is a good way to do it, but also giving out what we know about it. Would it be fair to unload, perhaps? Are there things that we could help you? Does that pain lead you to think about, what we would consider to be catastrophic thinking, or do you have these consequential thinking of, if I have knee pain, then I need to stop playing football? And why do you have those? We can have that conversation without being, psychologists. They're simply listening and engaging with your patient at a therapeutic level. So I think there's a lot of things we can do by addressing and listening to the story and knowing that pain is fluctuating. That is the normal course or trajectory of clinical, non-specific musculoskeletal pain.
Yeah, I love those thoughts, Morten, because I think that really individualized, subjective and objective exam. In terms of objective, it's like, how are they moving? What's going on in terms of the way that they're approaching a movement of that painful body part? I think it tells us so much, and it helps us to be able to create that narrative, because I think ultimately we're trying to understand why we hurt. And athletes are doing the exact same thing. And so I think that's where I guess I see that thorough, subjective and objective look at how they present as a person and as a whole person in that sporting environment becomes really relevant to consider, because so much of that we know can be contributors to pain. And so possibly even having those discussions and mapping out, well, let's talk a little bit about what was different on that day that you actually had a lot of pain when you were doing this training exercise. And I mean, even understanding the relationship or role that poor sleep can play in pain. That often can be, a real driver of those, all of a sudden you're feeling pain during this one movement or this one exercise that normally that's actually been fine. And for an athlete that will still attribute any pain that they feel to further injury means that actually maybe in their mind, they've potentially done something different this time and they've aggravated something. They've done something to make it worse. And so I think that aspect of the ability of their understanding to impact performance negatively is very much influenced by, I think, the cognitions that are taken from what they understand is happening. But it's also remembering that many of those changes, you're not consciously aware that, all of a sudden your protection factor is ramped up. Many of those things happen completely outside of our awareness, and they're how our system is meant to work. So I think that that understanding of the various contributors can also be really helpful then in framing their own individualized narrative of what we think is going on.
I completely. I was just thinking that also it means a lot if we as clinicians understand the relationship between, for instance, inflammation, tissue injury, and pain. So you can easily have inflammation, and I believe that's what sort of most people intend to say when they talk about overuse injuries. So you've done something and it will be gone in a few days, so actually underusing it for a period of time will help. Whereas that extended use of the word, where you just have continuous or persistent or intermittent pain that is caused by something, then hopefully most people will move, and you try to look for patterns. So if they move and the pain is fluctuating, there's a good chance you can keep looking for things that won't, give you any clues to how to do the therapy. But if you can rule out what you know it isn't, so you can rule out the sensitization aspects of it, which inflammation is leading to, then that would be the first sign of serious pathologies, including fractures and tissue injuries anyway. So actually knowing the nuts and bolts of neuroscience and how the nervous system relates to the pain sensation to the extent that we understand it as scientists, I think that is really beneficial, not just for the therapist, but also again for the athlete.
Thank you. I think we covered the second one. So third one is athletes being told they are injured can lead to unnecessary assessment and interventions, particularly when a clear clinical diagnosis is lacking, yet the reports of pain remain severe. We talked a bit about that, but Tasha, do you want to kick in with some expansion of that one?
Yeah, sure. And I think it probably actually relates back to your comment about the vibe in the clinical or the sporting setting and what we expect to occur. This is the trajectory. This is what happens. And I guess I think that becomes particularly relevant when we are looking at early surgical intervention. So I mean, some of the data, if we look into, they're not athletic populations, but in people that have, for example, undergone a meniscal repair or removal of meniscus, many times the long-term outcomes for them are very similar to people that haven't had the surgery. And granted, there are cases and there will be situations where in athletics and in athletes, it might be important to look at a surgical process or procedure because they are going back to very high level sport. But I also think that some of our evidence in that isn't as strong as we might expect because we've not actually done those trials to know it. And I think that's actually one of the things that are some of the biggest barriers is that the stakes are very high in professional athletes. And there's a lot of money and resources that are placed in there, and it's their career. So our ability to rock up there as researchers and say, let's do a randomized controlled trial and see how these athletes go when we do replace or remove or fix or remove a meniscus versus when we don't necessarily always have that capability. But I do think that some of those things, particularly if we can look within populations that we possibly can test in, so possibly not professional athletes, but high-level athletes, I think that actually has a lot of merit to potentially challenge some of the things that we think that we know. Because I think if we're already looking at updating our terminology of needing to be more precise and specific about injury, and the fact that it can go down this route of leading down to unnecessary interventions, there also is the relevance then of questioning, actually, when are those interventions relevant, regardless of the terminology we use, regardless if we don't happen to go down that possible sequelae of different treatment options. Sorry, my cat is going crazy behind me.
Can you please take that cat out of the box?
Yeah, I know. He's nuts.
That's fair.
Oh dear.
But so were you done, Tasha?
Yes.
That puts, I think, from a clinician's perspective, that gives that you need to be quite certain, you need to be quite confident in a world where things goes fast, and you need to like relax in your uncertainty that you can't be sure all the time. And that puts a lot of pressure on the healthcare practitioner and on the coach and on the peers, and not least on the athlete.
I think maybe part of it is that we have made clinical reasoning to be this grand thing where you cannot, nobody can really grasp the amount of diagnoses that are attached to musculoskeletal pain. When in fact, if you look at it, the majority of those things which we categorize as serious pathologies, they're really minimal.
Yeah.
And albeit we cannot find everything, there are indications that we can look for. And again, so a new pain needs more attention than a pain you've had before. And I would argue that we need to make sure we know what it isn't caused by to begin with. And then rather than using this, I'm not against in any ways a step care approach. I think that's a good idea, but just like the WHO pain ladder that was used for treating terminal pains or cancer-related pain, in the beginning, where you would start with the least harmful, most beneficial pharmacology therapies, and then you would move on and end up with something. For instance, opioids for treating terminal breakthrough cancer pain. I think that approach is being used to a large extent when it's not merited in athletes as well. So you would have, of course, orthopedic surgery on the top shelf. And I think for many athletes, it feels like I haven't been thoroughly assessed and maybe treated if I haven't had therapy in that sense. So if I haven't gone all the way upstairs,
yep.
And if surgery is on the top shelf, then it somehow, I've met a lot of athletes who say, well, if there's no way around it, I will have to have surgery. When we look at the evidence, though, surgery does seem to come out on top of the list. So it really helps patients, just not significantly more than anything else, but it is better. And if you compare surgery to sham surgery, which again is a weird concept, because you are doing something even if it's sham surgery, of course, but you're not doing the thing that we think is wrong. So let's say in shoulder pain, you can go in and you can clean the shoulder, or you can do subacromial space giving surgery, or you can look in with an arthroscopy and pick around and take the arthroscope out again and close up. And they seem to be working completely equally well, but both work slightly better than exercise. But if you look at the clinical benefits, both in the short term and in the long term, so 12 months, you don't see a clinical difference, but you do see a statistical difference. So I think, depending on how you read the literature, it will feel like the step care approach is merited. So we won't use surgery unless it's really important. But I don't think actually that's how the literature should be read. And I think the only reason we use it is because we haven't had this differentiation between, are you hurting? Is it pain itself that is the problem? Or are we looking for a thing that we can use to change the pain? Again, look at how the US and the rest of the world basically are looking at a musculoskeletal pain or even low back pain. You can see they're still quite engaged in surgery and injections, corticosteroid injections, and things that we here in Europe have discarded a long time ago in our guidelines. So there are, worldwide differences. But I think, again, coming back to why we did it, the infographic is a way to start that discussion. Do we need to use a step care with this patient? Will it really make a difference? Or would it be more beneficial to change our perspective and look at it as a multifactorial non-specific pain, for instance, which is not the same as saying the patient is a psychosocial case.
Thanks, Morten. So that kind of, I think you've covered most of what I want to cover. So that leads me to one of the big things. How do we implement this? What do we do? Where do we go to with this? Just a few suggestions. I don't expect going through all the way, but just some suggestions.
First of all,
go around this?
I think the IASP should acknowledge our topical workshop.
I agree wholeheartedly.
We forgot to clarify in the beginning that you're both making a living out of this, right?
Yeah.
You're quite biased.
Yeah. Well, that we are. No, I think discussing it, talking about it, and honestly also proof of concept. So I understand why an athlete who has a cultural support in doing the step care approach, looking for the thing that can be changed, and using this biomedical approach to treating sports-related pain, injury, disability, whatever you call it. I think that's merited to the extent that we need to show proof of concept. But I don't think we need to do a whole lot of new research studies and randomized controlled trials, given restrictions such as those Tash was talking about before. But what we need to do is to be open-mouthed and explain how things could actually be done differently, and then we could draw upon the treatment ideas and guidelines from other non-specific pain. And again, here's non-specific low back pain is an area where there's heaps of evidence to do exactly this. And I would say that there are, of course, differences in how athletes use their bodies and how dependent they are on their bodies to work and function and perform in their performance. But generally speaking, we are, biologically very, very similar. So there should be a good overlap. And I definitely think we have enough to come up with proof of concept, and that it is a case that we can actually apply it to the clinic and then little by little change the culture out there.
Yeah, I agree. I love that idea of proof of concept, because I think that ultimately that's where we have to start, is to, generate, even if it is starting to publish case studies of people that have those recurring persisting back pain problems that, have actually already tried surgery twice, and then we try something else. And I think those can give us insights into the possibilities of these sorts of issues, of looking at or considering the concepts of injury and pain as not synonymous, and having those conversations within the teams, seeing if we can get this, going. And I think there actually could be really interesting possibilities for sort of just using, ecological data that are there. So the fact is, they track injuries really well in sports teams. So what if we have, one sports team that we work quite closely with, and we actually work with that team to try to upskill and change at a cultural level, and compare injuries and compare how long are they off sport, how long are they. I would love to. I think that would just be so interesting to do, because I think ultimately that's the bottom line, is that if we want to make change in the sport field, it's allowing athletes to be healthier, to go back to sport quicker, and to ultimately have teams that aren't injured. And I purposely use the term injured there because I think that is relative to how it still is framed. So if we can change that conversation so that it's not how many of my people are injured, but it's how many of my people are doing well and playing at their best, because to me, then that encompasses both injury and pain, then I think that is a goal that certainly I would be supported by, I would say, people in the professional sphere, but also one in which you kind of can have your own little case study, which I'm a nerd, so I'm always up for that. But I do recognize, and I think you do as well, Morten, and you are saying it as well, Brian, that this is not necessarily meant to be a quick fix or a quick change. It's something that ultimately has to probably come from numerous different areas in order to sort of imbue that cultural system.
Yeah, just maybe to sort of tie a knot on that, and to say the perspective of what we're doing, because of course it's interesting. There are so many interesting things about working with athletes and their sort of willingness to go beyond the borders of what you would see. I was going to say normal people do.
Watch your mouth,
but again, yeah. but I would extend this to say if we can show proof of concept here and work here, and maybe in parallel, but also more particularly on a societal level in terms of work athletes, so industrial athletes, as you mentioned before, so people who are working with pain. We don't even know how many people are going to work every day with since the sort of perception of pain in their bodies, and how is it that so many people cope with it? I think we can learn a lot from the people who are coping with what can be considered chronic pain. So they are doing stuff which are, you know, for them it's maybe part of their everyday life, but they are doing it. And I would argue there's a range of people in high performance athletes as well who are doing it despite having pain. So that's a second aim, I think, looking at that and then drawing, you know, a parallel between the super high performing athletes and the industrial workers who are not working with the same sort of eagerness, I assume, and the willingness to go. Maybe you know, people with low income and uneducated jobs, they need to go to job. The working is part of their sort of living status, and they are just as disabled by the same pain that we're talking about in athletes. So I think the scope here is much bigger than simply getting top athletes to perform even better or more with pain. It is understanding the sort of, you could say, Formula One of musculoskeletal pain, and using that to spread it out, and understanding how can we help much more in, you know, within the whole performance on work issue. Because it turns out that just like sports, being active is good for your health, but so is being on a job. Having a job is also good for your health mentally and financially and many other things. So let's try and use this sort of change in culture and understanding of what pain is and isn't to actually help people stay active, whether that be in the workforce or as an athlete.
Yeah. Thank you. It's been an absolute wonderful way to start my Monday morning. Thanks, both of you.
Thank you for having us.
If people want to know more about you, where are you on social media and stuff like that? Or are you not that often on Twitter, or was that just happened by purpose that we got in contact?
Yeah, Twitter is probably the easiest place to get a hold of me. So I'm at Tash_Stanton. I realized after I made that I should not have used an underscore. It's very hard to find people when you do that. But yeah, that's probably the best place to follow and to connect with me social media wise.
What about you, Morten?
I am on Twitter at MHDK. And you can also find me at Aalborg University, where I work.
Okay, I'll put that in the show notes. Well, both of you, thanks for coming. As I said before, it was an absolute wonderful way to start this week. I'm happy that you choose to spend a lot of your precious time helping the rest of us understand your thoughts, not just the infograph, I can say that, but all your thoughts and ideas. So have a good one.
A pleasure, Brian. That was really fun. Thank you.
I'm glad you liked it.
You too, Brian. Thanks for having us. Bye.
Bye.